Good evening, everyone, and welcome again to the second part of our six-part series in how you can get more involved in treating patients with snoring and sleep apnea. I'm Dr. Richard Drake, and my partner, Dr. Guy Yatros, is with me. And we're going to talk specifically tonight more about the treatment options for sleep-disordered breathing.
Welcome, everybody. Just wanted to thank Keller for helping us put this on. As you know from attending the last seminar, Keller's a full-service laboratory. Now they're becoming highly involved in sleep apnea treatments with dental appliances. They're a full-service lab, provide various appliances, in particular the EMA and the TAP, which Rich and I use regularly in our practice. They're just a great lab, and they're dedicated to customer service and dental education.
Dental Sleep Solutions was started a few years ago by Guy and myself, and we have put together a system of operations, forms, letters, software, really is a turnkey system to help dentists implement this and become the go-to person in their community. And we hope that you will go to dentalsleepsolutions.com to find out some more about us. But this is not exactly about us tonight. We're going to talk about treatment options, and we'll just continue to move on.
If you want to know about us, there's a little bit about us on the screen. Suffice it to say that Rich and I have been involved in this between the two of us over 20 years. We've done thousands of appliances and made it a big part of our lives. Rich strictly does sleep apnea treatments in his office, and I'm migrating towards that very rapidly in my three offices too, which I just do sleep in.
As we said, this is the second in our six-part series. We also want to talk about the other ones coming up. In the middle of August, we're going to do patient evaluation and consultations. September, we'll do patient protocols. This would be specifically when patients come into your office. Have they had a sleep study? Have they not? How do we get them diagnosed? We get into a little bit more detail with that. In October, we will talk about titrating these dental devices. Where do we start patients? How fast can we move them forward? And what kind of side effects can we expect? And how do we deal with those? And last but not least, in November, we'll talk about marketing this part of your practice. And everybody wants to know about how to bill for these and get paid for them. And we will include that. And in addition, you want to talk about the in-person courses we have coming up, Guy?
Yeah, we'll talk about it at the end a little bit more, but we have two-day in-person courses, one in Orlando, August 5th and 6th, and one in San Antonio on the 7th and 8th. We're going to make appliances for each of the dentists to attend. If you send your impressions in ahead of time, we'll make either a TAP or an EMA appliance for you. It'll be a lot more hands-on. We get a lot out of these webinars, but nothing beats a hands-on course to really get knee-deep in dental sleep medicine. Before I forget about it, try to stay tuned for the whole webinar, because if you want to get AGD CE credit, we're offering an hour of credit for listening tonight. Tomorrow you will get an email with a link. Click on the link. There'll be a 10-question quiz you can take. Pass the quiz, you give us your AGD number, and we'll send you the CE credit. You need to do that within 14 days of receiving the email to get your hour of credit for attending tonight.
Our learning objectives tonight are very simply to understand the treatment options that exist for patients who have sleep-disordered breathing. We would like to also know which ones are effective in which circumstances, and we want to talk about the compliance of therapies as well. We're going to look at surgeries, we're going to look at CPAP, we're going to look at dental devices from tongue devices to mandibular advancement devices, and we're going to talk specifically about some of the things that you can look at in your patients that will predict success or failure with the treatment options that we choose to use.
Speaking of treatment options, what are the treatment options available for obstructive sleep apnea and snoring? There's various categories. CPAP, we all aware of that, and that's been pretty much what everybody seems to have gotten as a treatment option for someone diagnosed with obstructive sleep apnea in the past. Dental devices are rapidly becoming a big part of treatment. That's why you're here today, obviously. We're going to talk about some surgeries, weight loss and body position can be effective, and some pharmacologic treatment options as well.
One of the few pharmacologic solutions that we have for sleep apnea, and it really isn't a solution, is Provigil. The generic name of this drug is modafinil. The usual adult dose is 100 to 200 milligrams taken once daily in the morning. I have had a lot of patients who have been on this, and most of them say it feels like I had a nice big strong cup of coffee. So the drug itself is a wake promoting agent. You probably should be aware that most insurance companies will not cover this drug unless the patient is also on some other type of treatment therapy for sleep apnea.
Weight loss and body positioning. I think often, Rich, these are some of the underutilized methods of treatment, but it's also difficult to get people to do both of these, in particular weight loss. I mean, how many of us have been on a diet and tried to lose weight? Certainly weight loss will decrease apnea in most all circumstances, and weight gain is going to make it worse. If we can get our patients to lose weight, sometimes that can be a successful treatment, at least for the time being, even though we know that sleep apnea is a progressive disorder. Weight loss alone will not always solve everyone's apnea or get it under control. Positioning is something I utilize on a regular basis in conjunction with dental appliances. The patients who have apnea that's twice as prevalent in the supine position as in the lateral tend to respond real well with positional therapy.
Yeah, and I'd like to add a couple of things to that slide, Guy. One is, and I know for those of you who were on our last webinar, we went through that slide series of obesity in the United States, and that's a fascinating thing to me, and I like to talk about that and look at it. And I read the other day that at any given time in the United States, 70% of the population is on a diet. I find that hard to believe, but if we can agree with that at this point, and after 12 months of dieting, the average person gains between 5 and 10 pounds.
Gains weight, not loses weight.
Gains weight. So I think it's fair to say now we finally figured out why we're getting fat, Guy, and that is that dieting is the leading cause of obesity in the United States.
Might have a better chance getting people to wear their CPAPs than to be successful with their diets. You want to talk about good sleep hygiene, Rich? I think this is something that we need to be versed on as dentists.
Absolutely. And this should be a part of every single discussion that you have with your patients. You're going to learn more about these treatment options tonight. Again, the CPAP, the surgery, the behavioral modification types of things, the dental devices that we use. We'll get into a lot of detail with that at the end of this webinar. But right now, you need to make sure that the bedroom is a quiet, safe place. We use the bed only for sleeping and sex. We have a winding down time. If we're going to drink alcohol, we need to start cutting it off at 5, 6, 7 in the evening. We don't eat 12 enchiladas at 10:30 at night. We allow enough time. That's important. Sometimes I think we're tired because we go to bed too late and we get up too early. So the multimedia bedroom is especially true for kids. They're doing a lot of studies now, and we know that sleep apnea in children is linked to ADD and ADHD. And when you look at every single electronic device that a kid has in his bedroom, their GPA starts to go down. So we can certainly talk to our adult patients about this, but we can also bring the kids into this as well.
I think it's a very good point. A lot of the physicians don't spend the time, I've found, to talk to this. Certainly some of them do, but in general, the patients aren't very well versed on this. And if our goal of treatment is to not only lower their AHI, but make our patients feel better, feel more rested, sleep more soundly and better, understanding the concepts of good sleep hygiene are crucial. Let's talk about CPAP for a moment. CPAP stands for Continuous Positive Airway Pressure. The words we use are a pneumatic splint. It's basically like blowing open a balloon. If you think of the airway as a collapsible tube, the CPAP, you put enough pressure with the air blown from the CPAP machine, it blows the airway open. There's also two other forms of CPAP, that's BiPAP and AutoPAP. BiPAP decreases the air on expiratory breathing cycles. So in other words, when they're breathing out, the pressure goes down. Oftentimes, these are people who have a much higher CPAP setting and makes it more tolerable to the patient. And an AutoPAP automatically adjusts the pressures depending on the body position, maybe nasal obstruction, alcohol intake, what have you, during the night. So it's not mandatory that the patients put on AutoPAP have what we call a CPAP titration study, which is the study that is performed in order to make sure that the CPAP is titrated or adjusted to an optimal pressure to keep the airway open.
That's good, Guy. And I want to add, too, that when we ask patients, what's your CPAP set on? Most of them will know. They may say it's at 12, and that number is the centimeters of water that machine is actually adjusted to. So an auto PAP will adjust that based on some of those other parameters. A BiPAP will have two settings. It will be 12/8, for example. So the inspiratory would be 12, the expiratory would be 8.
I kind of think of the levels of CPAP similar to the Epworth Sleepiness Scale. 24 is about as high as you get. Of course, you never get a 0 with a CPAP, but when you see the pressures are down around 8, those are low pressures. So people that are up in the high teens oftentimes are on the BiPAP because of the high pressures.
I love these pictures you put together here, Guy. I especially like this guy on the bottom left. He looks like he's figured out some way to include a hallucinogen in the CPAP airstream there. But you get the idea of a couple of different mass and delivery systems. And I think we have a couple more here. Let's go to that next slide. This is kind of one of the new age types of treatments.
And look at the couple here. I mean, isn't this a nice way to spend your evenings as we go to bed holding hands with our CPAPs strapped together? I mean, we make a little fun of CPAP during our webinars and seminars. The truth of the matter is, if everybody liked the CPAP, you would not be listening to us this evening. The problem with the CPAP is the patients don't always wear them, like this couple here.
Here we have a CPAP delivery system on the right there, and just a graphic depiction on the left that we have sleep apnea, and we can use CPAP, do surgery, do dental devices, and there are a couple of different types of pills that we can take. And CPAP has a majority of the market right now. We'll get into the caveats of CPAP and the treatments option itself, some of the problems that people have, and why we think as dentists we're in the right place at the right time to continue to gain more and more of the market share on the treatment side.
What are the caveats of positive airway pressure? Anyone who's been in the sleep medicine field for any period of time have heard dozens and hundreds of stories about why patients won't wear their CPAP. We really don't need to list them here this evening. Just suffice it to say that some people have troubles wearing them, and the compliance is a big part of the problem. That is more or less why we're here this evening. The methods of CPAP aren't specific to the disease, and they're not always targeted specifically at the AHI. And respiratory failure, BiPAP in particular, is more suited for these patients with neuromuscular disease.
And again, we just have a visual depiction here of a CPAP delivery system that uses nasal pillows and goes into the nose. You can see the headgear, the straps, and everything. I just have one word for that: cumbersome. No, let me add another word. I like the word sexy too.
There's various different methods of applying the pressure with the nasal cannulas, as you see here. The most common is just nasal CPAP, a full face mask. But no matter how you slice it, it is cumbersome. There's no simple way of getting the air there, pressure to the lungs, to the airway rather, to make patients accept it better.
And lastly, about CPAP, we want to talk for a little bit about the medical model of how sleep disordered breathing gets diagnosed and the treatment entrenchment that CPAP has right now. That is what we're trying to overcome as dentists. Nearly every single patient who gets a sleep study and is diagnosed with sleep disordered breathing will have a physician recommend CPAP. Only about half of those patients will actually go get the CPAP, and then we can cut that down into about half, again, that will actually utilize it. So there's a big difference between when a physician hooks up CPAP in a sleep study and they adjust that pressure to where there's very little ink on the sleep study anymore. You'll hear that kind of as a dental sleep medicine parlance when you talk to physicians, and what they're referring to in that sense is that the apneas and hypopneas go away. So when CPAP is on and it's not leaking and the patient is sleeping, it's working well. The problem, of course, comes in the real world with people who won't wear it, who pull it off, the mask moves and it leaks, those types of things. So it's a very effective therapy, but the compliance is very poor. And we want to do something about that as dentists. let's talk a little bit about different types of surgeries that we can do, or our ENT or oral and maxillofacial friends can do. So let's go ahead to the next slide, Guy. My good buddy Kent Moore put this together for me. There's a lot of different types of surgeries that are on this slide. We're not going to talk about every single one of those tonight, but just as a reference for you, you have something to look at here. And I believe that the next slide, let's go to one more there, Guy, starts to break down these for you. If you think about the upper airway being the nose and the mouth down to about the Adam's apple, and we're going to do something to that upper airway surgically, we can do that within the pharyngeal area, intrapharyngeal area. These types of surgeries would be with the soft palate, the tongue, tonsils, adenoids, as we go down that area. And let's go to the next slide there, where we can talk about extra pharyngeal surgeries. We can work on the upper jaw or the lower jaw. We can work on the nose and the septum and the turbinates, sinuses, the hyoid bone, the little tiny bone down there. We can actually suspend that and move it around and wrap muscles around it and things like that, as well as actually go to the neck itself, where we can do lipectomies. We can remove some of that fat. So you have a bunch of different surgery options. We want you to be aware of these, that they can be categorized in different ways. And now we're going to talk about just a few of them in a little more specifics.
Yeah, and just suffice it to say that the surgeries either remove tissue to make the airway bigger, or they attempt to make the airway stiffer by making the tissue stiffer, or they reposition anatomical features of the airway to open up the airway. I think that's pretty much the three categories that all the surgeries, other than a tracheotomy, come into. Am I correct on that, Richie?
Yeah, that's a good point. I'm glad you pointed that out.
You'll have many patients come into your office and say, I had the surgery for sleep apnea, because the most common surgery is uveal-palatal-pharyngealplasty, or UPPP surgery, which is basically removing the tonsillar area, the soft palate as much as possible, and the uvula. And that's what most people consider the surgery. Shouldn't be taken too lightly to have this procedure done. It has one of the highest morbidity rates. You can read some of the other risks with the soft palate surgery. I think, Rich, don't you have a patient that every time they drink now, the liquid comes out through their nose?
Yes, Guy, I've seen this more than once. When you cut part of the palate out, if you cut too much of it out, then when you go to swallow, you don't have the top of that palate helping you do that, and sometimes it can go the other way. So velopharyngeal or velopalatal insufficiency would be where that liquid comes out your nose. So the ear, nose, and throat physicians who are doing this certainly don't want to have that happen, so they're becoming more conservative in how much of the palate they cut out, which of course makes the surgery itself less effective. So when people talk about the surgery that Guy talked about, know that it doesn't always work.
Yeah, according to Dr. Krieger and the Principles and Practice of Sleep Management, he quotes it at 40% effective. I've spoken to a few ENTs who say there's research and their own experience shows if done in the correct patient, it can be much more effective than that. In other words, someone who has large tonsils has an indication that this may work for them. But if just done across the board, it's not highly effective. And I always ask patients who've had this, would you do it again? And all of them say no, because it didn't work. And then I ask them, would you do this again, even if it worked? And the majority of the people who had it done say they would not do it again, even if it would work, because it was so painful. Genioglossus advancement. As you know from your dental anatomy back in dental school, the tongue is attached to the genial tubercles on the inside of the mandible. This section is cut out and pulled forward. So basically, we're pulling the attachment of the tongue in a forward position, making our patients more tongue-tied. It does have some effectiveness, but it can certainly have an effect on speech as well. Oftentimes, this is done in conjunction with what's called hyoid suspension, which we'll talk about in just a few moments.
And of course, we can do tongue reductions. I always think about biting my tongue when I'm eating something, and I just get a little overactive tongue, I guess, and bite that. But you can actually make incisions in the tongue and move tissue around to actually reduce the volume of the tongue. And again, very high morbidity and not very successful.
MMA surgery or telegnathic surgery is basically pulling the maxilla and the mandible forward. And it's one of the most highly effective surgeries for the treatment of obstructive sleep apnea. I think secondary only to a tracheotomy, if I'm not mistaken. It needs to be done correctly. Surgeons who do this have to have some knowledge of the airway and what their goals are. And there's evidence to show if a mandibular advancement device is an effective treatment for obstructive sleep apnea, that MMA surgery has a higher chance of success. Anything you want to add to that, Rich?
I have had maybe 7 or 8 patients over the last 10 years that have been involved in this in some form or fashion. And part of the challenge in doing this is it's hard to find an oral and maxillofacial surgeon anymore who will actually do this. The risk and liability is very high. The payment is very low. So most of them would rather sit back and take wisdom teeth out all day than run the risk and liability of something like this. However, it is a very effective therapy, and I like to talk more about this type of therapy in younger patients as well.
The chances of success by various studies are 85 to 95% if done correctly. Again, I think you hit on a key thing that getting insurance companies to pay for it is much more difficult than it used to be in the past, and that's probably part of it, as well as the risk associated with it. But next to a tracheotomy, it's got the highest success rate, comparable reduction to AHI of CPAP. So I have only had one patient who's had this done. Rich, as he said, had 7. So it's, pretty invasive surgery. So you don't have people lining up down the street to do this. Tracheotomy. You have any patients who have had tracheotomies, Rich?
I've only seen that twice, and it's not something I would want even my enemy to have. But of course, when everything else fails, we simply bypass the entire upper airway, and we put a hole in the windpipe there, and we put a filter on it, and we breathe through it. Let's leave that as a last resort.
Well, it is 100% effective. One thing, I do mention it to patients when we talk about the anatomy, because I think it shows them or makes them understand where the obstruction is. They understand that and also kind of highlights the tongue involvement in that when I show an anatomical photo and we talk about a tracheotomy. All right, dental appliances. I know that's what a lot of you are spending your evening attending this webinar and wanting to know more about. There's a lot of them out there. I don't know how many FDA-approved appliances there are now, but I think it's approaching 20 or more. They come in different categories. Tongue-retaining devices is one type of device we'll discuss in a moment. But far and away, the majority of the ones we do are mandibular repositioning devices. And then some surgery procedures that we've already talked a little bit about, which we'll talk more in detail.
In general, I like to explain this to patients that this is not rocket science. Just like CPR, we tilt the head back, we pull the jaw forward. Why do we pull the jaw forward? Because it opens the airway more. This is something that you can talk to patients about that they will understand.
Our goals of treatment shouldn't just be to lower the AHI on a patient. I oftentimes will explain to the patients that we have 2 categories as far as our goals of treatment. I call them subjective and objective. The objective is the AHI. The subjective is improving the sleep quality, decreasing the arousals, increasing the quality of life. So you can see the goals listed on your screen, but just think of it as we really want to make the patient feel better and at the same time lower their AHI to a medically acceptable level.
One thing I'd like to add to that, Guy, and I agree with you completely, is that obstructive sleep apnea is defined as a syndrome, and a syndrome is defined as a cluster of symptoms. So when we look at all of those types of things that are affecting people's lives, as you mentioned, you break them down into subjective and objective findings, then we address each one of those. We want them to sleep better. We want them to feel better. We want them to have more energy. We want them to exercise more, all of those types of things. So remember, it's not just to decrease the AHI. We want some of these other things to happen as well.
We talked about the practice parameters during our last webinar, but I think it's worth just mentioning it again. The American Academy of Sleep Medicine's guidelines are anyone who has mild to moderate apnea should be given a choice between a dental appliance and a CPAP. And anyone who can't wear CPAP for any reason, their next step should be a dental appliance.
You're going to hear people throw a couple of different terms around: oral appliance therapy, OAT, MADs, MRDs, MASs, and these are all acronyms for these types of things that you see here, but in general, we're talking about the same type of thing, just so that you know.
Yeah, and the physicians often call them orthotics, dental orthotic, too. I don't see that one listed there. So, yeah, we're all talking about the same thing. Don't get caught up in the terminology.
How do they work? What exactly is going on when we're doing this? The main thing I think that we're doing is that we're keeping the jaw from falling down and back. We are actually moving the jaw forward, and as we move the jaw forward, we move the tongue forward. Something about moving the tongue forward also increases the muscle tone of the tongue itself. And of course, there are muscles that attach between the palate and the tongue. So we're increasing the tension in all of these areas. The end result, of course, is that our airways getting bigger and staying bigger while we're asleep.
It might be worth mentioning that we not only open the airway in an anterior posterior direction, but it also dilates the airway in a lateral direction. So it's a 360 degrees increasing of the airway size through mandibular advancement devices and tongue retaining devices.
For those of you who are interested in this, there are specific muscle attachments and the way that anatomically we come together. And you can see these listed here, which muscles connect which and those types of things. So those are for the nerd guys out there. So let's keep moving.
Okay. Tongue retaining devices or tongue stabilizing devices. I can't say that I do a ton of these. I certainly do them, and it's something you should be familiar with. Pretty much reserve these for indications when a mandibular advancement device won't work. Either they don't have a good enough range of motion, or there's certain types of TMJ disorders that would preclude using a mandibular advancement device. Someone who's totally edentulous, upper and lower arches, unless they want to have implants placed, is pretty much their only option as far as a dental device goes. And sometimes maybe people going through orthodontics or going through dental work. It's a good treatment for them to utilize while their teeth are getting fixed in one way or another. Anything, other reasons that you use them, Rich?
No, that's good. The only comment I want to make is that these are very difficult to get used to. I tell patients that it takes about 6 months to get used to these things.
Right.
And in general, what we're doing is we're just physically pulling the tongue forward. Let's go to that next slide, Guy. And you can see here how the patient's looking at this thing saying, "What? You want me to put my tongue in that?" And then they just squeeze that bulb together and their tongue goes in there, and that's what it looks like. I remember my mom used to make these Tupperware popsicles. She would mix Kool-Aid and she'd put them in the little Tupperware thing and freeze them, and then you'd take them out, and I'd always try to get that last little bit of that cold stuff out of that, and I get my tongue stuck in one of those things, and that kind of reminds me of what that is. But there are fewer indications for these, as Guy talked about. They're a little bit harder to get used to, but it's certainly a tool that we want to have in our back pocket.
The way that our area of shining in the sleep medicine is compliance, and compliance on tongue retaining devices are lower than custom-made mandibular advancement devices. So again, we use them when mandibular advancement devices are contraindicated for one reason or another, or maybe this guy, maybe or lady, sorry. Maybe that's from wearing one too long. Is that what that's from, Rich?
Yeah, the caption there, of course, is, "Are there any side effects from that TRD that Dr. Yatros made you?"
It's the one Dr. Drake made is the only problem. The only comment I would have. All right, mandibular advancement devices.
All right, moving right along. We talked a little bit about the tongue devices. Now we're getting into the more specifically the dental mandibular advancement devices. That's what we call them. lots of different designs out there. You saw some of the pictures there. How are they different? What type of material do we make them out of? How do we adjust them? Do they go forward? Do they go back? Can they move up and down? How do they hold on to the teeth? Do we have to heat them up before we put them in or not? Can I do this in the office, or do I have to send it to the lab? We'll talk a little bit about this as we go through some of these. And again, Keller's helping us do this webinar series, and we certainly support them and everything that they do. And they make the TAPs and the EMAs, and we're going to talk a little bit more about those. But as we move on to the different types, mechanisms themselves, you can see from this slide here that these devices are adjusted either from the midline or from the sides. And when we do it from the middle, we can say it's either through compression or tension. Are we pushing or pulling? That's kind of splitting hairs. We won't get into that. But if we go to the next slide there as well, Guy, we'll get into other devices that compress or push or pull from the sides as well. I think this is an important distinction when we start to look at our patients and their tongue size and those types of things. And we'll talk a little bit more about that as we continue this webinar tonight.
You know, when we do these webinars and seminars and talk to people getting involved in dental sleep medicine, that's always one of the big questions. What's the best device? What's the best appliance? And there really isn't a best one for everyone. Certain ones work better in certain situations. Certain people are more comfortable in certain situations. There's always a give and a take. If you have one with attachments on the sides, that makes the tongue room better, which is the whole goal, is to get the tongue forward. But those might irritate the cheeks. So you got the ones that attach in the midline. Well, they take up a little more tongue space. That are maybe arguably less irritating in the cheeks. That's only one example. So you've got to kind of look at the pros and cons of all the appliances out there, and certain ones might work better for certain people. I often will say it's kind of like a car. I'm a big guy. I like riding around in an SUV. That gets me from here to there in a more comfortable way. You may like a sports car, and that may suit your style. Both of them are going to get you where you're going. Just some of them work better in certain situations. I'd rather have a sports car if I'm trying to get there fast, and I might rather have the SUV if I'm going off road. So I hope that analogy makes some sense to you and understanding that as we go through these appliances, that Rich and I don't use any one appliance. We use multiple appliances in varying circumstances.
That was well put, Guy, and I do like your analogy. There's more than one way to get from point A to point B. I would like to point out that we as dentists have not done a very good job of studying this up to this point. As of today, when we're doing this webinar for you guys tonight, this is the extent of the research that I've been able to find that compares one device to another. There are a lot of studies out there now that use dental devices. There are some studies that are even using them correctly and titrating them. But we've not done a real good job of comparing one device to the other. So most of the information that we have out there is from practitioners like Guy and myself who have been doing this for a lot of years and have treated a lot of patients, but it's still anecdotal. For those of you who want to look at some of this information, here it is for you.
Yeah, Rich, I agree that there's not as much research, and hopefully we'll prove that as years to come. But one thing I think I can say, and you can say from our experience, is some people tend to do better than others with dental appliances. And again, this may be roughly based on research, but a lot on our own experience. There's certain individuals who have a higher chance of this working, in our opinion. On the left, you can see the things you want for someone to be a success, and on the right are things that may be more prone to failure. Normal weight, female, younger, positional apnea, in other words, worse than a supine position, retrognathia, basically how low the hyoid bone is or how high it is. The higher the hyoid bone, the better chance of success, and a shallow MP angle.
Yeah, that's the mandibular plane, Guy. I'm
Okay.
sorry, I know I get into abbreviations all the time, and
Yeah.
sometimes they're hard to
Okay.
follow. But that is that when you look at somebody's face, do they have a real long face top to bottom, or do they have a very short square face? So when they turn in a profile situation, you see that lower jaw line. And if it's relatively shallow, it makes more sense that if we move their jaw forward, we would have more room there. And if their chin is very, very low and that mandibular plane angle is very steep, then it doesn't work as well. The other thing I want to point out that when we review medical histories, we need to pay attention to past medical histories. People that have Lou Gehrig's disease, myasthenia gravis, even things like multiple sclerosis and some of these other things that may play a part in what we're doing and how we do it and predictive success that we're hoping for.
But to make that clearer, anyone with those type situations or those type medical disorders, rather, have less of a chance of a dental appliance helping them. On the right, you can see the things that are for failure, but essentially the younger people that aren't overweight who have anatomical reasons for their apnea and positional therapy are good. People who are overweight, who don't have the anatomical considerations, don't work as well. And the more you can move your jaw forward, the better off we are. If you can't move your jaw forward at least 6 millimeters, that's what ROM is, the range of motion. It's going to be difficult to successfully treat them, at least with a mandibular advancement device.
Good point. Thanks for pointing that out. Let's talk about some of these. This is the TAP. This is one of the ones that Keller makes. And it's the TAP 1, which is the old one that had the little knob sticking out, and you could actually adjust it. If we go to the next slide, that's the TAP 2. They took that knob off, and now you insert a hex key into that, and you can see how that goes. Now we're on the TAP 3, and they also make the TAP Elite. They're different designs for how that hook goes in there. The TAP Elite actually has different vertical components as well as horizontal, so you don't actually have to cut those things off and move them like we used to do in the lab guy. It makes it a lot more simple, and Keller can do all of this for you with the TAP. You've seen the TAP 1, 2, and 3 there. As we move along to the next one.
I want to say I got to play with that TAP Elite at the AADSM recently when we were there in Minneapolis, and I think the TAP was already a great appliance, but it really made a great appliance even better, basically by having a lot more flexibility. I think it takes up a little less tongue space with the new bar, the way that they have it configured. It's got more lateral range of mobility than the slide that's shown right here. I think they made some really big improvements to something that was already a very successful appliance.
That's one thing we can count on Keith Thornton doing for us is he's a tinkerer and inventor, and he's always back there in the lab trying to make it better. So moving on to the next slide here, we have the dorsal design. This is one made by SomnoMed, the Somnodent Mandibular Advancement Splint. And you almost have to pick one of these up and hold it in your hands to see how that works. The top right there is you see the jack screw. That front part of that actually moves forward, and that dorsal design off the bottom then rides on the front part of that jack screw that's moving forward. So with a dorsal design type device, you have a little more range of motion. You have the ability to get your tongue up and forward a little bit more. But again, we have to take into consideration some of the things on the cheek. And sometimes, I know, Guy, you like to use the hooks on this, don't you?
I always put hooks for elastics. Oftentimes, the dental appliances work better if you fix the jaw in a position. In other words, don't allow vertical opening. One of the nice things about this appliance is it does allow vertical opening. Sometimes that'll be a problem when the patients get too relaxed and their jaw falls down during REM sleep and what have you. And they can put little wires to hook orthodontic elastics to it to help minimize jaw opening. And you can take this appliance that's not working that well and then add those elastics, and you can have a really big increase in the effectiveness of it. So I always add the hooks just so you have them if you need them. And one thing I want to mention too is that the dorsal design refers to that wing that's got the circle around it. There's various other appliances out there. I can think of about 3 off the top of my head that are very similar to this, utilize this dorsal design. SomnoMed just happens to be one of them.
The SUAD, strong upper airway dilator. We like to think of this as the Herbst on steroids. so to speak. It is basically a Hertz design, but it has a metal substructure framework. And I know that you like to use these, especially on people who are heavy bruxers, don't you, Guy?
Yeah, I have a sleep physician, one of my first patients actually, and he's been wearing appliances for about 10 years and literally broke about everything until I put him in one of these things. I mean, I call it the tank. It'll hold up very well. It is a little bit intimidating. Some patients don't like it because of the way it looks. They've tried to improve that recently with making them in colors now as well. But it's a very functional appliance that allows a lot of lateral movement and holds up well.
The Moses is another type of mandibular advancement device that uses a jack screw. You can see one on the top right and the top left, and it just gives a little bit more room for the tongue. You can't move sideways or up or down at all, but it's another one of the tools that we have out there.
Yeah, it doesn't necessarily look like this too. It's usually just all blue. They have the colors here just so you can see the different parts of it. The EMA is one of my favorite appliances. It is something that you look at it and you say, well, that's kind of a simple design, but simple is often better. There's no metal pieces to get gunked up with poor oral hygiene or to break. The way this particular device works is there's different lengths of rubber bands and different rigidities. As you put a shorter band on it, moves the mandible more forward. As you put a more rigid band on it, secures the jaw better. But it's really about the smallest appliance that I know of that you can make that's FDA approved for obstructive sleep apnea and snoring. Wear one quite often myself at night.
I especially like the EMA as well. And this, again, is one of the ones that Keller will make for you. And I would recommend that this be one of the ones that you guys get started with as you consider doing this.
It's also one of the least expensive ones on the market.
Here's a picture of someone who has had a custom-made mask done that has been fitted to a tap. So inside his mouth is a tap device, and that maxillary plate has two side screws and a center screw. If we take those side screws out, we can put that metal post in there that you see sticking out the middle of the blue piece there and take an impression of someone's face. You can then have this custom mask made, and the advantages of this hybrid type therapy would, of course, be that, number one, as we move the jaw forward a little bit more, we can lower the PAP pressures. So we might go from 12 to a little less than that. Here you can see a different type of mask that may also be used with the tap. This is a full face mask, and there are just various ways of attaching dental devices. It seems like more and more of the dental device manufacturers are coming up with their version of how you can mate their appliance to a CPAP machine. And this is as you get into this and you do this more and more and you become the go-to person and the expert in your community, you're going to need to know how to do some of this hybrid therapy. I wouldn't recommend it as your first case, but it is something that you're going to learn to do. And at this point, we want to make you guys aware of it.
It's also a great way to start once you get more comfortable, a great way to network with the medical community, to work with them as a team, decreasing the adversarial sentiments that might be out there.
Good point.
The best thing about doing dental appliances for the treatment of obstructive sleep apnea is that we have the treatment that most people would prefer to do. I compare this to doing a crown in your office. The first thing that the patient says, well, can't you put a filling in it? And you spend a lot of time talking to the patient about the virtues of a crown versus the negatives of putting a large restoration in that may break or what have you. When it comes to treating obstructive sleep apnea, all you have to do is explain the treatment options that are out there. And if they are a candidate for a dental appliance, that's what they're going to want the vast majority of the time. We don't have to spend our time convincing patients to choose the treatment option that we have. All we have to do is convince the patients that they need to treat their obstructive sleep apnea, and they will want a dental appliance the vast majority of the time. That's a real breath of fresh air for us dentists who are constantly having to fight an uphill battle to get patients to do the proper treatment.
When we think about which device we want to use on which patient, some of the things that I want you to start thinking about is how much can they move their jaw? Guy mentioned before that they need to be able to move their jaw at least 5 or 6 millimeters, or we probably can't help them. If somebody comes in and they're a class 3 occlusion and they can only move their jaw forward 3 millimeters and they have severe obstructive sleep apnea, that might be a patient that you might steer more towards CPAP. But considering that they have at least a normal range of motion, which would be more than 6 millimeters, then we can. You all are trained in looking at the temporomandibular joint. Is there active disease going on there? Do they have muscle splinting going on? Maybe 5% of my patients, I will make some type of anterior deprogrammer or something like that to help calm down the muscle spasms that many of these patients have. We know from the literature that we're seeing more and more studies come out that relate bruxing to sleep. We could do a whole 1-hour webinar on that for sure, but suffice it to say that those problems do coexist and contribute one to the other. Obviously, people have to have teeth. We think in order to do a mandibular advancement device, it would be best to have at least 6 sound teeth in each arch. When we think about what type of device we're going to make, we can also think about, do they need to have a bunch of work done? Can we still treat them with a dental device? Well, we can. We might make a tap on someone and we might use thermocryl, which is a type of material that you heat up and mold to the teeth. Then we can work on a tooth, do a filling, do a crown, refit the device and not have to make it. Obviously, we hope you're doing periodontal probing and things like that. We don't want to put any undue pressure on teeth that are periodontally involved. A lot of times on maxillary lateral incisors, I will simply take them out of the appliance. I'll adjust the facial areas of maxillary lateral incisors so that we don't put any pressure on them. Looking at the size of the tongue, they open their mouth, is their tongue scalloped? When their tongue is very big, I tend to use devices in general where the device advancing mechanism is on the side rather than in the front. Nasal patency is something that we always want. Always. The better your patient can breathe through his nose, the better your dental device will work. So this opens up immediately a two-way referral street to your ENTs. So I recommend that all of my patients do everything that they can within their power to help them breathe through their nose better. And lastly, we will think about, do we want to use a device that locks them in or allows them to move a little bit? Some people do not like the idea of getting locked into a device and not being able to move. It makes them a little claustrophobic. So again, that's something that you might just want to think about as you talk to patients about this.
Real good advice, Rich. I agree with everything you said there. In particular, the ENT referral. That's where I get a lot of my patients. And looking at the nose, I can't even overemphasize that enough. If you want your devices to be successful. Well, which one are we going to do? You know, here's what I did. I know Rich did this because he and I have had conversations about this. But just pick a TAP or an EMA and just start making them. Make them on yourself if you happen to have snoring or obstructive sleep apnea. Make them on staff members. Make them on staff members' spouses or on your patients. But just pick one, make 10 of them, and then move on to the EMA if you start it with the TAP. And you're going to learn some of the pros and cons as you go through with this. If you come to one of our hands-on course, we can go into more detail about the pros and cons of each of them. But nothing will make up for you just doing them. So just get out there and do them. They're both good appliances. If someone told me that I could only use one appliance for the rest of my life, we would get by, wouldn't we, Rich? I mean, we would still be able to successfully do this on many, many patients. You'll find which ones work better in certain situations, which ones you might like better in certain situations by just doing them. So just get out there and do them.
When we talk about the TAP, you can use the TAP 1, the TAP 2, the TAP 3, the TAP Elite. There are differences in the positions and the sizes of the hooks. You can make these with DuraSoft or the dual laminate, or you can use thermocryl. You heard me mention Thermacryl before. No, Guy doesn't use that much. I do use it a lot. It's a little bit more of a pain to use from the dentist standpoint because it takes longer to fit. You have to actually put the device in very hot water. It goes from an opaque type of looking material that's very hard to something that's clear and becomes like Play-Doh. And then you seat it in the mouth and you push it up real hard and you tease it in and out. And then you take a scalpel and trim it. The things I like about Thermacryl is that you can make it tighter or looser, and you can work around patients that need dental work. So certainly someone who has very short clinical teeth that you might have to actually try a little bit harder to grab onto, you might consider this, as well as someone who's undergoing dental work. Otherwise, the Durasoft, the dual laminate that most of you have already used, is a very good choice as well, and is probably actually more comfortable for most patients. Guy, can you talk about the EMA?
Sure. I do a lot of EMAs. Is one of my favorite appliances. The advantage to the EMA is that you have a lot of movement with the jaw, and it's very small. Typically, what I'll do for impressions, we prefer polyvinyl siloxide impression material. We take a bite with a George gauge, which is a protrusive bite, usually with the white 5 millimeter fork in it. We always start the device with the number one bands, the white ones. They're the longest ones. And then we can move more forward as we get the smaller bands. They just finished reordering and adding additional band sizes now for the EMA. And I think there's 9 links it comes with now, if I'm not mistaken. So you've got a lot of options and links, as well as 4 rigidities with the bands. But start with the white, which are the most flexible, and the number one bands, which are the longest, and then we can move the patients forward as we need to, as we titrate the appliances. No great secrets on how to do it. A couple of polyvinyl impressions. Make sure you get the distal of the molars. I think it'll help prevent tooth movement. Some of the appliances that don't wrap the distals of the molars tend to get teeth separations and open contacts between teeth. And so ensuring that you get an impression all the way back to the back of the molars is very important to prevent that.
Good point. Now, you mentioned taking a bite with a George gauge. You didn't talk about the starting position. When you take a bite, where do you like to start somebody with an EMA, for example?
You want to take into consideration their level of apnea, their range of motion, any TMJ or muscle discomfort history that they have. But in general, I start between 40 to 50%, most of the patients, between 40 to 50% of their maximum protrusion. So in other words, if they go on a George gauge from -5 to +5, that'll be a 10 millimeter range of motion. We may start them at -1, which will be a 40% of their total range of motion. If they have worse apnea, no TMJ problems, some other reasons that I feel that maybe they should be moved more forward, we may start them at 50 to 60%. But seldom do I go over that 50 to 60% because it's much easier to move the appliances forward than to get somebody out there too far to start with and get some muscle discomfort. What about you, Rich? Is that about where you sound the way you do it?
Yeah, I like that. That sounds good. I think in general, it's probably the most forward position that a patient can tolerate comfortably for 3, 4, 5 minutes in your chair. So a lot of times we'll actually take the bite and then put it back in, and while we're talking about the next appointment and what we're going to be doing and things like that, and then we just, if they go, oh man, that's really hurting my jaw, well, we can actually move it back. We don't have to necessarily take another bite. We can tell the lab we want to move it back. But you're absolutely right, about 40 to 50% most of the time.
Good point. I do always put the George gauge in for a few moments, ask them if it's comfortable, and then again, once they've set with the bite registration in their mouth for a few moments. Absolutely. Want to make sure it's comfortable to them. That also sets up a comfortable expectation for them mentally as well. They feel like they have some control over that.
Okay, we're getting to the end of our second webinar. Again, we want to thank everybody for spending your evening with us. The textbook, Oral Appliance Therapy and Obstructive Sleep Apnea Hypopnea Syndrome, a clinical study on therapeutic outcomes by Dr. Arnad Hakama. It is a great next step for you guys to get. The American Academy of Dental Sleep Medicine has the rights to distribute this, so I know you can get it through them. I know we've also talked before about the Principles and Practice of Sleep Medicine. That's that 57-pound textbook that we've talked about before, but it's a great textbook, and you can certainly knock yourself out with that one. And I think more than anything, I want you guys to just commit to learning more about this. You wouldn't have gotten to this point in life and be dentists if you couldn't sit down when you decided to learn about something and learn about it. And obviously, we hope that you will join us with our next webinar next month. And Guy wants to talk about some of the Keller specials too that they're doing for you.
And Keller has a special thanks for you attending our webinar series. If you'll contact them for $49, you can receive an in-office dental sleep medicine marketing kit, which includes an EMA device, a TAP waiting room DVD, a TAP and EMA brochures, the Epworth sleepiness scale, coupons and discounts for your next TAP or EMA case, a sample letter of medical necessity. Just contact them at Keller at kellerlab.com. Keller is a great lab, and they're also a good resource for help when getting started in dental sleep medicine.
And let's not forget about our hands-on courses that we're doing with Keller. The August 5th and 6th is in Orlando, and October 7th and 8th in San Antonio. It's finally starting to cool off a little bit here in Texas about that time. These are 2-day hands-on courses. You'll get a device made for yourself. We will go into much more detail about all of the things that we're talking about here. You can register online by going to info@dentalsleepsolutions.com, giving us your email address, and we'll hook you up and get you headed in the right direction with that.
Yeah, and if you can't make the hands-on course, we're certainly going to try to get in as much detail as we can via a webinar in the times allotted. Our next one's coming up August 17th. Hope you can make it, where we're going to go over patient evaluation and consultations. And then September, we're doing patient protocols. October, we're going to talk about specifically titrating dental devices and how do we manage these side effects that the devices may cause. And November 9th is marketing to practice and how do we get paid for this, medical insurance and billing, which is always a well-attended subject. I just want to reiterate the CE credit procedure. Tomorrow, everyone who is in attendance tonight will get an email from the Dental Sleep Solutions to the email address that you signed up with. You'll need to click on the link, take the test that it'll link you to, supply us with your AGD number, and you'll receive an hour of CE for attending tonight. Make sure you do that within the next 14 days to receive your credit.
Again, thank you all for attending tonight and taking time out of your busy schedules. I want to thank Keller Lab again and Jason Tierney. I want to thank my partner Guy Yatros and Nathan Drake for helping us put this together. And we're going to stay on and answer just a couple of questions for you, but we're already running out of time. And the first one I see here, Guy, is which appliance do you use most often?
I would say I use personally the EMA, the TAP, dorsal design, and the SUAD, or that'd be the top 4 appliances that I presently use. What about you, Rich?
I would ditto that. And as more appliances come out on the market, we're constantly evaluating these and looking at them. But those are certainly the tried and true. They have different advancement mechanisms, and I think if that's all I had in my back pocket, I could probably treat pretty much everybody effectively with that. Again, we're going to recommend that you guys use the EMA and the TAP to get started with, and we'll go from there. Our next question deals with what are the typical side effects that you most often see?
The number one reason that I would say that someone can't wear one of these appliances is muscle or joint discomfort, but it's usually muscle discomfort. We don't really get TMJ joint changes. There's been several studies that have shown that no higher incidence of joint changes with patients wearing mandibular advancement devices. So that's one thing. We also see tooth movement, open contact. mentioned earlier today. I think that's the second category. Various types of tooth movements. Bite changes are probably the most troubling thing that we do, and we'll talk about doing some bite exercises to get the jaw to go back. And you get some tooth discomfort. Sometimes the appliance will push on a tooth that's pushing on it maybe towards the palate, or you ask the patient, what does it feel like the appliance is doing? They say, yeah, it feels like it's pushing my front tooth inward. You relieve the appliance, and that's how that's addressed. We're going to talk in detail at one of the later webinars about how to manage these, but I'd say the three categories that are most prevalent are tooth movement / bite changes, put that as one, tooth discomfort, and then TMJ discomfort, which is primarily muscular in origin. Anything to add to that, Rich?
No, we'll go into much more detail in those types of things in our October 12th webinar, and we hope that you will join us. We have 4 more of these coming up: August, September, October, November, and thank you guys again for spending the evening with us, and we look forward to presenting next month.
All right, thanks a lot. Have a good night.